Hello, this is Vivek. Welcome to Doctor Talks.
Here, we chat with the best doctors about diseases and conditions they treat. Our guest today is Dr. Prashant Makhija. Dr. Prashant is a practicing neurologist at the prestigious Wockhardt Hospital, South Mumbai, India. He has qualitative experience in the field of neurology, including its various subspecialties such as epilepsy, sleep medicine, stroke, headache, movement disorder, neuromuscular, and neurobehavior. Dr. Prashant has many publications to his credit in national and international journals, and he has authored book chapters in neurology textbooks. He was awarded with Young Investigator Award at the 10th World Stroke Congress. Welcome, Dr. Prashant.
Hello Vivek, thank you for inviting me to Dr. Talks.
Which health condition are we going to discuss today, doctor?
Today we'll be discussing about headaches, a very common symptom amongst patients coming for consultation with a neurologist. And at some point, most of us have had a bad day because of headache.
Can you help me understand headache better, doctor?
So speaking in layman language, headache is simply a pain located in head. Whereas if we speak in medical terms, International Headache Society defines the boundaries within which this pain should be located. So on the sides, if we draw a line which comes from the outer margin of eyes, which goes backwards up to the ear, and on the back, above the nape of the neck. So it is the pain located in head within the confines of these boundaries. Headache can be a symptom of underlying neurological or systemic disorder, or it can be a primary disorder in itself.
Can you share some common facts about headache with us?
So headaches are the most prevalent neurological disorders. In fact, it is the most common neurological symptom for which a patient seeks neurologist consultation. If you look at the epidemiological data, it is estimated that nearly 50% of the general population, they will have headaches during any given year. It is reported that more than 90% of the population, they will report lifetime history of headache. Headache is in fact the third leading cause of disability worldwide. And if you look at the amount of analgesic consumption, headaches account for more than 13,000 tons of aspirin consumption annually worldwide.
And do we have classification of headaches in terms of different types of headache?
So headaches are basically classified as primary and secondary. Primary headaches, they account for majority of the cases. Nearly 90% of the cases are primary headaches, wherein there is no underlying structural brain pathology. So if we were to do a scan in such cases, a CT or MRI of the brain, it comes as normal. These primary headaches, they can present as episodic disorder, that is, the headache episodes occur intermittently. It can also present as a chronic disorder, wherein the patient has headaches for majority of days of a month, that is mostly 15 days a month, and he or she continues to have this way for at least 3 months. These chronic headaches are usually the most disabling primary headaches. The secondary headache, they account for nearly 10% of the cases, wherein there is underlying brain pathology which is responsible for the headaches. And this pathology can be either vascular, that is related to diseases of the blood vessels. It can be infective, which is due to infection either of the coverings of the brain or the brain substance or both. Or it can also be because of a space occupying lesion in the brain, such as a brain tumor. So these are the common causes of secondary headaches.
Doctor, can you share more in detail about primary headaches and specifically, and I'm guessing here that migraine must be a primary headache, right?
Yeah. So primary headaches, as I said earlier, they are the ones without any underlying structural cause. The most common types are the tension type headaches, which has been reported to have a lifetime prevalence of nearly 50%. This one usually occurs in relation to stress, lack of sleep. The symptoms in tension type headaches are mostly non-specific. The patient, he or she may complain of a stretching or tightness around the head, and the pain is usually not that severe. There is often an antecedent history of stress in such cases. Also, the symptoms are not as dramatic as in migraine. Migraine is another variety of primary headache, and it has been reported to have a prevalence of around 18%. It is relatively more common amongst females. There are certain rare types of primary headaches also, and these are together grouped as trigeminal autonomic cephalgia. So in these types, apart from the headache of variable duration, patient may also complain of congestion and tearing from the eyes and running nose. Now talking about migraine in particular, it is usually an incapacitating headache, which usually starts as from the one side as one-sided pulsatile headache, which then progresses to involve the entire head. And during an episode of migraine, the patient may also complain of either a sensation of vomiting or they may vomit also. They may have intolerance to light and sound, and some may also complain of associated giddiness. Some of the patients with migraine, prior to the onset of the headache, they may complain of aura, which is actually a kind of premonition that within the next 15 to 20 minutes, they are likely to have headaches. This aura is usually in the form of blurring of vision. So some may also experience a zigzag flashing lights, and as soon as the aura subsides, patient usually starts having a crescendo pulsatile headache. An episode of migraine lasts for a minimum of 4 hours, but in some severe cases, this may continue up to 3 days also. But not all patients with migraine will have aura. Those one without the aura, we call them as common migraine or migraine without aura. And aura is experienced in roughly 25% of the migraine patients. And one particular patient may have both types of episode. Some of these may be accompanied by aura and others without it. Patients who have frequent migraine episode, they are also able to identify in some cases certain triggers which can precipitate a migraine episode. Some of the common ones I will list. One is exposure to bright sunlight. Another is lack of sleep. And also patients who fast for prolonged periods. And if they skip their breakfast or lunch, they are prone to have a migraine episode. Some experience a migraine episode following exposure to strong perfumes. So these are some of the factors which can precipitate a migraine episode. But not all individuals will have same triggers. They can vary from individual to individual and even within an individual from time to time.
Now, I just have a query because you mentioned about common migraine and migraines where there's an aura. Are these two migraines different in terms of their severities and the treatments are different, or underlying they are both same?
So as I mentioned earlier, one particular patient may also have both types of episodes. So severity and treatment does not vary. It is just the symptomatology. Some patients will have aura, which gives them a warning that they are likely to have headaches within the 15-20 minutes. But the severity of symptoms apart from the aura do not vary. Neither does the treatment.
All right. And do you recall any specific case of migraine which you treated recently and you still remember it?
Okay, so I can remember a case of a young lady. She was about 27 years of age. She had come to me with frequent disabling headaches. Because of the frequent episode, she had in fact stopped going to office and she had taken a break from work. Before she came to me, she had consulted several physicians and she had also been to eye specialists. So her headaches were attributed, some attributed it to stress, other thought this was related to refractive error of the eye. She had also underwent multiple brain scans, which were all reportedly normal. And as she did not find any relief, she started self-medicating herself with over-the-counter analgesics. which we often see in migraine patients. So this particular lady, over time, she became dependent on these analgesics. And many of the times, she was taking multiple analgesics in a day. And when I reviewed her medical history, her headaches were like migraine in nature. But because of the self-medication, she had developed what we call as medication overuse headache, which is a common complication we see particularly in chronic migraine, wherein the painkillers, instead of helping the patient, they become part of the problem itself. So I took time to explain her regarding the condition, and I counseled her on the judicious use of painkillers. I then started her therapy for the migraine, and the first time she came for follow-up, that was about 3 weeks, and there was a significant noticeable change in the frequency and intensity of headaches. And after about 2 months of the therapy, her headache had completely subsided. After that, I started tapering her medicines. Presently, she is free from her headaches and is not taking any painkillers. So it is important that patients who have frequent episodes of headache, they must consult a neurologist rather than subjecting themselves to self-medication, which can lead to complications like these, in particular medication overuse headache.
Rightly said, doctor. And at this point, I would just want to share a couple of interesting data points with our listeners. Nearly 1 billion people worldwide suffer from migraine, as per World Health Organization. And there is a 2018 documentary movie which explores the history and mystery behind migraine. Listeners who are interested can go to the website outofmyheadfilm.com, or they can find it over IMDb. Now, coming back to our discussion, doctor, what are the danger signs of headache?
Okay, so there are certain situations wherein if the patient is experiencing headaches, he or she should seek an urgent consultation. So I will list some of the important red flags. The first one is first or worst headache of life. So if a person experiences headache for the first time, also if the intensity of headache is so severe like never experienced previously, he or she must seek immediate consultation from a neurologist. Another important red flag is if the onset of headache is sudden, that is, if the headache shoots up immediately, then this is another indication that we are possibly dealing with something serious, perhaps a rupture of the blood vessels supplying the brain structures, and this demands an urgent attention. The third important red flag is if there are associated neurological symptoms. That means if the patient is having headaches and these are accompanied with certain symptoms and signs such as sudden weakness of any limb, or if he or she experiences double vision, or if he or she has associated difficulty in walking, then one should seek a consultation with a neurologist to rule out any secondary cause of headache. Another important red flag is headaches in elderly population, particularly those who are more than 50 years of age. Headache in such population should never be ignored. They must be taken seriously and should be thoroughly evaluated for secondary headaches. And another important red flag is if the person is experiencing a progressively worsening headache, particularly if it is worsened by changing the postures, in particularly bending forwards, or if the headache increases on coughing and sneezing, then this may be a mark of secondary headache and requires evaluation.
What are treatment approaches for primary and secondary headaches?
Okay, so first let me talk about secondary headaches. In secondary headaches, treatment would depend on the underlying cause. So, in all patients who are suspected to have secondary headache, they should be evaluated by a neurologist. And in most of these patients, they will require a scan of the brain, which could be a CT or MRI, depending on the clinical circumstances. Some of them may also require specific scanning of the blood vessels which supply the brain, or some of them may also require analysis of the brain fluid, which we medically call as cerebrospinal fluid, which is an important part of evaluation, particularly in those who are suspected to have infection of the brain. If the patient has headache because of the brain infection, then he or she will require treatment of the same, which will be with antibiotics, antivirals, depending on the cause. Likewise, headache, which is secondary to rupture of the blood vessel, which supplies the brain, they will require intervention to seal that rupture. And a headache, which is due to a brain tumor, that may require a neurosurgical intervention. Now, coming to the treatment of primary headaches, for primary headache, treatment would vary based on the syndromic diagnosis. So, a patient with tension type headache, apart from the symptomatic painkillers, they will require counseling regarding lifestyle measures and also treatment of the underlying stress. In migraine, which is another type of primary headache, treatment would vary based on the severity and frequency of symptoms. Similarly, for autonomic cephalgias, which are rare types of primary headache, there are certain specific medicines to treat a particular headache disorders. But the key to treatment of primary headaches is proper evaluation by a neurologist. So once a right syndromic diagnosis is reached, appropriate therapy can be initiated under the supervision of a neurologist.
Just to understand the treatment approaches for migraine, can you elaborate on it?
Okay, so as I said earlier, treatment of migraine varies based on the severity and frequency of episodes. I usually suggest a three-pronged strategy to treat migraine. The first is preventive. So migraineurs, particularly those who have frequent episodes, are often able to identify triggers, which I mentioned earlier also. If a patient can identify his or her triggers, best is to avoid them. Some of the environmental triggers which I mentioned earlier, such as bright sunlight exposure, strong perfumes, there are certain food items also which are known to be precipitants of migraine, in particular cheese containing foods, which is a common ingredient in pizzas. Pickles is another type of food which can precipitate a migraine episode. Apart from that, there are certain artificial sweeteners, preservatives, dark chocolates, which females are particularly fond of, and red wine in males. So these are some of the common triggers which can precipitate a migraine episode. And identification and avoidance of these triggers can significantly reduce the requirement or dependence on medicines. The second part of strategy is abortive therapy. So as the name suggests, these are painkillers to abort a headache episodes. For patients with mild to moderate episodes, they can usually be managed with over-the-counter analgesics such as aspirin and paracetamol. These are the common ones. And those who have prominent nausea during the headache episode, they may require a combination of anti-emetic medication with painkillers. And these medicines are to be taken at the onset of episode during, or somebody who is experiencing an aura during the aura phase. Patients with severe episodes of migraine, they require certain specific medicines. We call them as triptans. And some may also require injectable analgesics to get rid of the severe headache episodes. The third type of therapy is the prophylactic therapy. This is usually recommended for patients with frequent episodes. And the guidelines suggest that the person should have at least 4 to 5 episodes of disabling headache per month. That comes as about roughly 1 per week. So these prophylactic medicines are of different classes, and they are chosen based on a particular patient profile and their tolerance to a particular type of prophylactic therapy. These have to be consumed daily, and they are taken for roughly about 2 to 6 months. The duration can vary from person to person depending on the severity and frequency, and they are to be taken under the supervision of a neurologist. The aim is to reduce the frequency and intensity of episodes, and once the episodes are well controlled, these are usually gradually tapered and can be discontinued. At the end, I would like to reiterate that the patients who experience frequent headache episodes should consult a neurologist rather than self-medicating themselves. And with treatment under the supervision of a neurologist, they can get back to their routine and continue with their daily living.
Dr. Prashant, talking with you was very informative. We learned about headache,
primary versus secondary headache, and we also discussed in detail about migraine and its treatment approach. Some of the key points which you highlighted included avoiding the use of over-the-counter drugs and consulting a neurologist at the right time. Any important point which we have missed?
I think we have discussed, as you pointed out, the issue of medication overuse headache, which is particularly common among patients who have frequent migraine episodes. And they, instead of consulting a neurologist, go about self-medicating themselves. So it is important that they seek consultation from a neurologist, because medication overuse headache significantly complicates the therapy of migraine. Another important, which I would like to highlight once again, the red flags which I listed. So anyone who is experiencing these red flags, they should seek immediate consultation from a neurologist, because in certain cases we may be dealing with something very serious, and if the treatment is delayed, the prognosis can be disastrous.
Dr. Prashant, thank you for taking time out from your busy schedule and talking with Dr. Talks.
Thank you, Vivek. It was my pleasure to be on Dr. Talks.
Dear listeners, please share and spread awareness about headache, their types, and warning signals by sharing this talk with Dr. Prashant. Please do not ignore your headache and take required medical help where needed. Cheers till we meet next time.